All right. Well, I am showing a minute past the hour. We're going to go ahead and get started. We've got a very full program, some fabulous panelists for you all today. Just by way of quick introduction, I am Eleni Tsigas, and I am the Chief Executive Officer of the Pre-eclampsia Foundation. We are super excited about today's webinar. Quick note that we are recording this, so please be aware of that. And also be aware of the Q&A button at the bottom, not the chat, but the Q&A button on your Zoom screen. That is what you will use to post any questions that you have for our speakers. And do post them as we go along because we are leaving time at the end of the webinar to get to some of your questions. If we can move to the next slide, I'll just do a quick introduction for those of you who are not familiar with the Pre-eclampsia Foundation. We're super excited that this is our 25th year. Our mission is to improve the outcomes of hypertensive disorders of pregnancy by educating, supporting, and engaging the community, improving healthcare practices, and advancing research so that we can ultimately find a cure for this life-threatening disorder of pregnancy. We are also the organization that spearheaded Preeclampsia Awareness Month. And so we're super excited. The activity this year has been phenomenal. It is National Preeclampsia Awareness Month. We're in the final days of it. And this is an important initiative to allow all of us to collaborate and work together to advance public awareness about preeclampsia and hypertensive disorders of pregnancy. And we do this through partnerships with other nonprofit organizations, with clinicians, with researchers, and families who have experienced preeclampsia. In all of these campaigns, we do recognize that we aren't speaking to just one single audience. We have a lot of preeclampsia survivors and their families, healthcare providers who are doing a lot of phenomenal work and even innovation in the clinical setting, including doctors and nurses and midwives. We have researchers who are working tirelessly, and many times they are also caring for patients. So our messaging around Pre-eclampsia Awareness Month needs to speak to all three audiences. We encourage you to grab the QR code that you see on your screen, where you can then access many of the graphics that we've produced, and you can share them on your social media sites as we end our final couple days of Pre-eclampsia Awareness Month. So why does the Pre-eclampsia Foundation even care about preeclampsia tests? Why are we talking about them, and why does this matter to our audience of patients and their families, and of course to providers and researchers? Well, the biggest challenge is that hypertensive disorders of pregnancy, and I think our clinicians today would agree with this, while we do have many known risk factors that you can see on your screen here, the reality is that it can happen to any woman in any pregnancy. That's the bottom line that we talk about anytime we start focusing on risk factors. You can have no risk factors and still develop preeclampsia. I certainly know that from my personal experience, having developed preeclampsia twice, more than 2 decades ago now. I was a low-risk first-time patient who had literally none of the risk factors on the sheet and developed severe preeclampsia twice, early onset, which resulted in the loss of my firstborn baby. There is something important to think about as we talk about preeclampsia tests, and that is understanding that there is a lot of terminology that you're going to hear and that you maybe have heard in the news or in some of the reports coming out. And the language includes words like screening or diagnosis or risk assessment, and maybe some other words, predictions. There are a lot of terms that are used in talking about the tests that are being developed for preeclampsia. I do want to help everyone understand that there is a difference between something that is a screening test and something that is a diagnostic test. And in general, a screening test is something that's going to check for the risk of a disease happening before symptoms appear. It may provide an early stage assessment for trying to prevent or getting in front of a potential treatment. And the example that I'll use, it's not a perfect example, but I think for many of us women on this call who are the most obvious audience for preeclampsia, maybe an analogy would be something like breast cancer and mammograms. When you go to get your mammogram, which you should get at regular intervals, the results of that test do not tell you that you have breast cancer or that you don't have breast cancer. It's looking for signals that you may be at higher risk. So a lump may be discovered. And that lump is a screening test that says, oh, this person may be at much higher risk for developing breast cancer. We now need to do further studies and further analysis. And then the gold standard becomes a diagnostic test, like a biopsy, where they're actually extracting those cells and putting them under a microscope and determining, yes, this woman has breast cancer, or no, it's not that. So that's not a perfect analogy to what we're talking about today, but it does give you some sense of the difference between screening for your risk of developing a certain disease or disorder and then a diagnostic test, which tells you that you actually have the disorder. And then I'm going to add another layer, which is maybe a diagnostic tool, which doesn't tell you definitively that you have or don't have something, but that is used in combination with other clinical criteria to help a physician diagnose you and determine what it is that you have going on. All of this matters when we talk about preeclampsia and all these tests that are coming out, which should become a little clearer to you as we work through our speakers today and some of the information. For preeclampsia, the risk of any pregnant patient getting preeclampsia with severe features is about 1 in 20 pregnancies. When you're screening for risk, your provider is going to look at that base risk and then layer on some of those earlier risk factors that I mentioned. Is this patient as increased risk? And then determine if more intervention, like an aspirin, might be warranted or an aspirin prescription. Our speakers are going to dive deeper into this distinction as they're reviewing what it is that we're learning through these preeclampsia tests. Now, there's been a lot of headlines in the news lately around some of these tests, and I'd say they've been popping up over the last 2 or 3 years, especially with this promise that the field is now developing better ways of predicting and diagnosing preeclampsia. One of the most common phrases that we've all heard from survivors who have developed preeclampsia and had disastrous outcomes was, if only I had known, my outcome could have been different. We are absolutely doing better about patient education about preeclampsia. Less moms are now saying, I'd never even heard of the word before. But they're still struggling. We're all still struggling to figure out who the heck is going to get it and whether those who are diagnosed with it actually need to be delivered right away or if they can stay pregnant for a while and give them a little bit more time and give the baby a little bit more time in utero. So that's why we're here today, is to talk about some of those tests and see what's on the horizon and what could absolutely change the outcome for many of our moms moving forward. So I'm going to introduce my colleague, Dr. Ira Bernstein. Dr. Bernstein is the chair of our medical advisory board. He is also a professor and university scholar in the Department of OB/GYN and Reproductive Sciences at Larner College of Medicine at the University of Vermont. He served on the ACOG task force along with myself and about 14 other people to develop the hypertension and pregnancy guidelines that really changed the face of today's clinical practices. He, as I mentioned, he currently chairs the Preeclampsia Medical Advisory Board, and he is going to be introducing our speakers in just a moment. So Ira, I will let you take it away from here.
Great. Thank you, Eleni. And I'll say good morning, good afternoon, and good evening for all of those joining us from different parts around the globe. And it's a pleasure to have all of you engaged and participating. It's my pleasure to co-moderate this discussion with you and the team and to introduce our 4 fantastic colleagues in the field of preeclampsia research and clinical care. I'd like to point out that each one of them is a trained subspecialist in maternal fetal medicine And they are all engaged in both academic scholarship and in providing clinical care to those with preeclampsia. So the foundation team will post each speaker's full bio in the chat section, but I will introduce them all right now before they go through their presentations. Our first presenter is Dr. Cornelia Graves. Connie is a maternal fetal medicine subspecialist who serves as a medical director of the Tennessee Maternal Fetal Medicine and medical director for perinatal services at the Baptist Hospital, which serves the greater Nashville area. She'll be giving us a history of the changing understanding of preeclampsia over time and how we've come to understand it in recent years. Our next presenter will be Dr. John Kingdom. He is a high-risk obstetrician, maternal fetal subspecialist from the University of Toronto, having recently stepped down as chair of that department. He has a clinical and research focus on placenta-mediated pregnancy complications, which include preeclampsia as well as placenta accreta spectrum disorders. He'll be sharing his insights about current research that suggests preeclampsia may in fact have multiple subtypes, and what that could mean for prediction, prevention, and diagnostic tools. Our third presenter will be Dr. Doug Walkers. Doug is Professor of Obstetrics Gynaecology and Reproductive Sciences at UC San Diego, and he will walk us through how new FDA-approved blood tests that measure certain markers of placental function are being used in the hospital setting here in the US. In addition to clinical care and teaching, Dr. Walkers has co-authored numerous abstracts and articles, and his work has appeared in the journal Pediatrics and the American Journal of OBGYN, among many others. And rounding out our presenters is Dr. Tom McElrath. We will pivot to his talk about the possibility of prediction on the horizon, with who Tom is a professor of obstetrics, gynecology, and reproductive biology at the Harvard Medical School and a professor of epidemiology at the Harvard T.H. Chan School of Public Health. He is also a practicing clinician at the Brigham and Women's Hospital in Boston and has recently joined the Murvy team as their vice president for clinical development, with Murvy developing new methods of risk stratification for adverse pregnancy outcomes. So this will be our sequence of presenters today.
And Dr. Graves, if you'd like to share your slides.
Connie, you're on mute.
There. Good afternoon. I'm pleased to be able to present today on the history of preeclampsia. And I think it's very important for us to understand why we're here and why we're talking about these markers. Well, preeclampsia is a disease of theories. And the disease, from a historical perspective, was about the eclampsia, because preeclampsia means that you are prior to having a seizure. The eclampsia comes from the Greek word meaning lightning. And so therefore, much of the focus was really on preventing women from having what they thought was epilepsy or the seizure. Now, interestingly, in the 4th and 5th century, taken from some of the African and Chinese areas, the people of that time felt the womb moved around the body. And they felt that an unhappy uterus was the cause of many ailments that actually happened in women. And so for preeclampsia, they thought that basically what was happening is the woman either was wet or dry, and that the dried up uterus was actually in search of moisture. So they then classified preeclampsia as 4 types of convulsions. And those convulsions included being part of the head or seizure, part of the stomach, probably what we know now as HELP syndrome, part of the uterus, which is probably somewhat an eruption, and then the chilled extremities, which was probably what they thought was edema. And I found this is extremely hilarious because they thought the uterus was a living thing inside of another living thing. And can't you just imagine your uterus saying, I'm going to get up out of my pelvis and I'm just going to go around and mosey and figure out what's going on in the body for today. So as Eleni pointed out, preeclampsia actually is very common in pregnancy, but what people don't understand, it accounts for 1 in 5 maternal deaths, 1 in 7 premature deaths. And unfortunately, the incidence of preeclampsia is increasing in this country. And there are significant disparities in maternal outcome. We know that women of color, in particular African American women and some of our indigenous populations, are 2 to 3 times more likely to die from complications of preeclampsia than their non-Hispanic white counterparts. So let's talk about a little bit about preeclampsia and what it kind of looks like. Actually, preeclampsia, or the disease preeclampsia, was not used until the 1900s. But in 1821, they thought it was a disease caused by toxins in the blood. And so then in 1843, they found that there were similarities in the kidney, are what we call where the kidney is affected, a glomerulonephritis, and the seizures. So preeclampsia was given the name Bright's disease at that time. In 1885, high blood pressure was then recognized as a feature of Bright's disease. And I want you to really think about this, because I'm going to make a point in that maybe we need to think about preeclampsia in the same way now. 1902, the word preeclampsia was finally used, and it was described as high blood pressure without seizures. In 1967, the identification of placental dysfunction. 1982 is when we finally gave HELP syndrome its name. And then in 1983, there was a brief deviation where preeclampsia was thought to be caused by a worm. And then now we're going to focus in the 1990s. Now think about this, on the multi-system end organ presentation of disease and endothelial dysfunction. So you can see our understanding of preeclampsia is relatively new. The treatment has also changed over time. In the Middle Ages, of course, there was a concentration on religion and faith healing. Patients get charms and prayers. Because in the 17th and 18th century, they thought it was caused by toxins, they did bloodletting to let out the toxins. Patients were giving opiates. There was a period of time where pregnant women were restricted from meat. It was also the development of lying in hospitals. Lying in meant that the woman came to stay until she either had a seizure or delivered her baby. And in the 18th and 19th century, there was the prevention of preeclampsia. Many of you who are in my age group will remember your mother talking maybe about a dark room, giving large doses of opiates, and then trying to delay delivery. In the 20th century, 1906, right after we started using the preeclampsia, magnesium sulfate was introduced, and it was recognized that delivery cleared the disease. But since 1960, very little has changed. We do routine prenatal care. We do hospitalization. We put the patient on bed rest. We evaluate systems for symptoms of preeclampsia, and we do blood pressure management. And so in the 21st century, there's a focus on the 2 stages or more of disease, the abnormal implantation and the maternal response to the abnormal implantation, and then rethinking those toxins as angiogenic factors. And as we go over time, I just wanted to point out that the progression of preeclampsia, as I said, the toxemias of pregnancy, followed by hypertensive disorders, then pregnancy-induced hypertension. So even our classifications have changed over time. But in 2013, the ACOG task force came up with the classifications of hypertension that we were recently spoke of. Preeclampsia and eclampsia, proteinuria was not required. Remember, that was one of the things we first established, with or without severe features. I remember when I trained, we had mild preeclampsia, which I never thought made sense because I didn't understand how someone could be mild pre-seizure, but that was what we thought about. Chronic hypertension of all causes. And we know that having pre-existing high blood pressure increases your risk, so you can have superimposed preeclampsia than gestational hypertension. But what I want to leave you with in the end is that preeclampsia affects almost every organ in which we in the mother. And I think this is really important because if we go back to the focus on toxins and the effect of preeclampsia and the fact that hypertension was discovered late, as I always tell my patients, preeclampsia is not about your blood pressure. It is about the fact that your blood pressure is just a manifestation of the many things that can go on in preeclampsia, including your placenta, kidneys, liver, blood, brain, pancreas, lungs, gut, eye, heart, and spleen. So Our current practice limitations is we previously had no specific lab markers. The diagnosis of preeclampsia requires a significant amount of clinical acumen. I tell my residents there are 122 ways for preeclampsia to present, and just when I think I know all of them, 123 then comes up. There's poor indicators of progression, and there has been no risk stratification. This has led to the delay in care, a lack of recognition, and as we previously talked about, those maternal deaths, harm to mother and baby. And I'm going to stop here so we can move on to our next presenter, but I hope this has laid the groundwork for you on why these biomarkers are so important as we move to better understand this disease.
Thank you, Connie, for that background. We're going to hold on answering questions and posing questions until we've completed all the presentations. So next up will be Dr. John Kingdom from the University of Toronto. John?
Oh, hi, everybody. Thank you very much indeed for asking me to join from Canada. For those who don't know me, I'm based in Mount Sinai Hospital, which is Canada's largest high-risk pregnancy program. And we've been using placenta growth factor real-time in clinical decision-making since 2017. So I have a lot of experience, but I won't talk in depth to that because that'll be the Doug's talk. So I just want to talk to you just in broader terms about management. So we tend to think of patients that present early around the periviable period, or patients that may require NICU care from a iatrogenic early cesarean, is largely having placentally driven disease, and placental analysis in these kind of patients is abnormal in at least 90% of patients. And at least 90% of them also have dramatic abnormalities, especially in placenta growth factor, but also in S-split, which we'll come to in other speakers. And for later shades of gray of the disease, the extent of the placental pathology and the deviations of the growth factors is just not as dramatic, but it's still the same spectrum. And then intermixed with that then are the maternal characteristics that can make either type of disease a lot more severe. So these relate to maternal age, BMI, and concurrent medical comorbidities and mode of conception. We've been using some machine learning tools to tease out some of these clusters. But in essence, basically, early severe placental disease is the most important driver early on. And those diseases are not as dramatic later on, but often compounded by the mother's condition. I'm just going to make a few other brief comments. I think that questions are always great in maybe a 1-hour panel. Some other comments just for you all are that we track anybody now admitted with preeclampsia for about the last 7 or 8 years. And because of the availability of PLGF testing, we're much more accurate in our diagnosis. And we're not seeing a lot of HELLP syndrome presenting anymore in patients who have continuing care from early pregnancy, or HELLP syndrome patients are now transports in from elsewhere who are not actually getting earlier screening. Final point I wanted to make at this stage in the webinar is that in November of last year, we reported on a really big screening study in 10,000 patients. So we now do PLGF screening at 24 to 26 weeks during GDM screening because the screening characteristics are very precise and allow established basic interventions to help patients, such as access to appropriate care, steroids, and appropriate fetal monitoring. We also use PLGF testing in prognosis and management options for patients in high-risk clinics earlier with the disease. Finally, in terms of clinical management, one of the things we're learning is that maternal heart rate is proving to be a super curious and interesting and very simple clinical tool. Patients with early onset disease with low PLGF present with hypertension, of course, but they often have quite a low heart rate. And it's only now with oscillometric blood pressure measurements in the last 5 to 10 years that we actually know the patient's heart rate. We never did before when we used mercury sphygmomanometry. So subtle bradycardia is actually the patient's telling us that they're vasoconstricted. And those patients need vasodilatory therapy. And in our experience, unless vasodilatory therapy is used in patients with low PLGF and early hypertension, they will almost certainly fail on labetalol and require vasodilation. So we use early aggressive vasodilation in patients with low heart rate, especially with low PLGF levels. Last comment, we're on a rebirth for uric acid in Canada. So the three tools we really rely on are uric acid, urine PCR, and PLGF. I'm going to stop there because the next two speakers I'm really interested in hearing about, and I'd love to join the discussions. And I thank you all for inviting me to join you from Canada. Thank you very much.
Great. Thank you, John. Next up is Dr. Doug Walkers from UC San Diego. Doug, I don't know if you have any slides to share, but feel free to do that now.
Okay. All right. I think I'm sharing. Do you all hear me okay?
Yes, we're good.
You are. Okay. All right. Let's get up to the beginning here. So, yeah, thank you very much for asking me to present today. And I'm really honored to be here with my co-investigators and to all of you around the world. It's a very good opportunity to understand what's coming in the future. And this is really an exciting time over my short career in this field is to see these changes and to recognize that a better diagnosis really can mean better care for mothers and babies. So I just wanted to start, if I can, with a really brief case, something that may seem so simple to us, but if you can imagine that you're a 35-year-old first-time mom and you're at 35 weeks at the clinic in the afternoon and your blood pressure is a little bit high, 144/88. It's the first time your doctors notice that. So they send you to the hospital for a workup. This is a very common occurrence in obstetrics. And at the hospital, your blood pressures are kind of labile. They're normal at 135s, but you can jump up to the 160s occasionally. And the triage nurse quickly asks you how you're feeling and goes through a list of questions. And do you have a headache? Well, yeah, I kind of do. How's your vision? Well, I got kind of blurry vision sometimes. You might complain of some abdominal pain. All these things may be elicited at the time that you present and could be potentially findings of preeclampsia. Standard lab tests would usually be ordered for a patient like this, and you might find something like a slight elevation for these liver enzymes, which it might indicate liver injury. The platelet count might be a little bit low, but there's no protein in the urine. So you can look at this simple case and really interpret it in different ways. If you're on the surface, you might think, oh my gosh, there's two blood pressures above 160. It's been over 4 hours. This is severe preeclampsia, and the doctor tells you you need to be delivered. You undergo a labor induction at 35 weeks, might fail, you might end up with a C-section, baby's in the nursery. Another interpretation, which could be legitimate, is that the blood pressures are really labile due to your anxiety and being in the hospital. And maybe if you're a little overweight, the cuff is too small, and over time, those blood pressures could go back to normal. Your headache and blurry vision can also be explained because it's late at night, no one fed you, and you're anxious, and you have abdominal pain from contractions. Platelets can drop in a normal pregnancy, and that can be confused for preeclampsia. And liver enzymes are not specific for this disease. They can be up for increase for other reasons. So another interpretation is you don't have preeclampsia. You can go home with monitoring. So which diagnosis is correct? How do we know which patient to induce, which patient to let go? And unfortunately, preeclampsia is like this diagram of the blind man and the elephant, where each of us might be seeing different aspects of this syndrome, not recognizing what is really underlying the whole process. It's really exciting to see the other researchers on today who were looking at other aspects of how to figure out what is the physiologic process, not just what is the syndrome. This quick slide, please don't read it all, is just to show you what we face when we go through this differential diagnosis for preeclampsia. These are the latest ACOG definitions, and they are numerous and confusing, and again, not specific. So as a physician, I can tell you it is hard to make a diagnosis of preeclampsia in every case. Sometimes it's a slam dunk, but oftentimes I'm scratching my head. Now, about that patient we started with, what would be the outcomes if we just watched that woman and to see what occurred with observation instead of delivering? And there's a couple studies that have looked at these late preterm patients to find that, yes, sometimes something bad evolves and we need to watch this patient. But by and large, most of these patients would have a good outcome if they just met those simple criteria. For example, death and eclampsia, morbidities, and placental abruption, all very low or non-existent, and uncontrolled hypertension, about 25% ultimately over time, but about 34% of those patients need to be delivered by C-section. And for the perinatal outcomes of that patient, again, relatively good fetal outcomes, and these are with women who actually have preeclampsia. So the bottom line is that no adverse maternal or perinatal outcome might be expected in about 2/3 of those patients. 1/3 of them do go on and get disease. But as that case illustrated, we don't know which one that is. So is there a better way to diagnose preeclampsia? Well, I really like to step back, and Connie mentioned this, and Dr. Kingdom as well, that there are biological reasons to develop preeclampsia. If we can elucidate these, then we can use these to identify and stratify patients for risk. And just quickly, we have the placenta developing early on. It's sending factors into the mother's body. And if there are baseline defects in placentation, leading to low oxygen level, defective development, perfusion mismatch. These can release the so-called toxins that we heard about earlier. These toxins may be of many different biological types, but we've learned to focus on these angiogenic factors to recognize that they control the mother's endothelial function, the lining of the blood vessels, ultimately responsible for the symptoms that we're seeing down the line, such as hypertension, edema, proteinuria, or even seizures. So what are these angiogenic factors? Well, I'd like to introduce them now so that you can recognize them through the rest of this quick talk, but there are pro-angiogenic factors. These are placental proteins that are made to help the maternal endothelial cells grow, to be quiet, to not constrict. Specifically, these are placental growth factor, or PLGF. We've heard us mention that before, or other factors as well. And they have receptors that are located in the endothelium. And there's also anti-angiogenic factors. This was a new discovery in this investigations of preeclampsia, showing that the placenta actually produces soluble receptors to these proteins. So the little Y here would bind the placental growth factor. This receptor is called soluble FLT. And when it's produced in excess, it will bind up the free placental growth factor, removing it from circulation, essentially denying the mother's body access to the placenta growth factor. This classic study from years ago, New England Journal of Medicine, shows that in a normal pregnancy, in blue, the level of the soluble receptor, the anti-angiogenic factor, will increase. But in black, in patients who have preeclampsia, there's a very high circulating level of the receptor. And for the placental growth factor, the good guy in this, the angiogenic factor, levels in normal pregnancy in blue should rise, skyrocket actually, much higher than in any other state of physiology, and decrease that term. But again, in black, patients who have preeclampsia, very low levels of placental growth factor. So this difference in the expression of these factors could be useful for diagnosing preeclampsia and understanding the disease. So indeed, a working model of preeclampsia is evolving that shows that the healthy placenta produces a normal amount of placental growth factor and not much of the soluble receptor, but the sick preeclamptic placenta overproduces the anti-angiogenic factor. So what's happened in the last 10 years or so, bench to bedside? We've moved from research into having clinical laboratory testing for both of these factors. These blood tests are rather quick and easy to obtain. They're just obtained off a simple maternal blood test. Turnaround time for analysis can be as short as 1 to 2 hours if you have the machines in access in your laboratory. And the cost is certainly not prohibitive compared to all the other tests that we used to do. So this is some studies that just show how good these factors are in relating to the clinical diagnosis of preeclampsia. This initial study just looking at placental growth factor, and about 290 patients almost with a high rated preeclampsia showed that if the factors were normal, which is in this case this not a negative predictive value we're looking at, the likelihood of developing preeclampsia in 2 weeks was only 2%. So 98% did not develop the disease with a normal placental growth factor. And this little red line on the side here is showing us that compared to factors like uric acid or blood pressure, the high shoulder here says that the placental growth factor is a superior test for delivery with preeclampsia than even the same markers of preeclampsia. Another study that looked at the ratio of the soluble FLT to placental growth factor in 2016 similarly demonstrated very good negative predictive values that in women with a normal ratio of the anti to the pro-angiogenic factor, the likelihood of developing preeclampsia in 1 week was less than 3%. So this is certainly a test that could help us identify that low-risk patient. The likelihood of developing preeclampsia if the tests were abnormal was only about 14%. So this is important to recognize that the test does not always identify those who go on to get sick, but rather those who are healthy and don't need intervention. A study in the US also looked at placental growth factor, similarly with very good negative predictive values for different outcomes of preeclampsia in 2 weeks or 1 week, for example, 90, 93, 91% for negative value. And the time to deliver, the time needed to deliver a patient here on the x-axis is much longer in patients who have a normal placental growth factor. Similarly, if you look at outcomes, not just the diagnosis, these composite adverse outcomes are low in patients with a normal placental growth factor, 0.8% likelihood compared to almost a 10% for those who have an abnormal low placental growth factor. So again, this biomarker is telling us which placenta is healthy, which patient is more likely or less likely to have an adverse occurrence. The most recent study published and one that's gained a lot of attention is the PRACIS study looking again at the ratio 2022. It was performed in over 500 patients, and similar to the other data we just looked at, the likelihood of progressing to severe preeclampsia in women with a clinical diagnosis, if you have a normal ratio, the likelihood is 4% or less. 96% remain healthy. The time to delivery is longer for those patients, and the likelihood of even developing severe disease is so much better predicted by the biomarker than looking at blood pressure or protein or uric acid. Similarly, just to confirm, if we're looking at the outcomes for mothers and babies for either maternal or a baby perinatal outcome, the composite risk for an adverse outcome is really low, about 3% for the mother with the normal ratio and about 26% for the fetus or the newborn. And if it's an abnormal ratio, almost 16% for mothers and 80% for the infant. Now, have these biomarkers been used in clinical practice? Well, you've heard from Dr. Kingdom that in Canada, they've already invested heavily in this and are using this for managing and making decisions. This is just some studies that show that when the biomarkers are introduced into the standard clinical paradigm, the time to getting a correct diagnosis was 64% faster. And therefore, the rates of a severe maternal adverse outcome were lower, 68% lower, when doctors had access to these biomarkers. So kind of to wind up here, I just want to say that the new evolving management, at least at our institution, where we have access to these biomarkers, is to, in those cases with an uncertain diagnosis that are preterm, we look at the ratio of SFLT to PLGF. And in those patients with high risk, we know that they are at risk, but not necessarily when an adverse event would occur. But really more importantly, those with a normal ratio are at exceedingly low chance of having a preeclampsia related adverse event. And so we can manage patients differentially based on those factors. Those with the low ratio might be able to go home shortly after a quick evaluation. And those with a high ratio either staying in the hospital, being administered steroids to prepare for prematurity, and instituting high-level testing would all be part of that paradigm. So what might we expect from the use of biomarkers in the future? Well, as I said earlier, really identification of a low-risk pregnancy to help with all the confounding that's currently present in the clinical diagnosis. Better risk stratification for the high-risk patients in those group of women with suspected disease. We can depart from the cumbersome symptom and laboratory testing, which leads to so many false positives, not rely so much on hospitalization, streamline care pathways, save money as well. But one caveat that I think we have to be aware of is that just looking at placental biomarkers will not necessarily help us to detect or exclude non-placenta mediated adverse events. So for example, a patient with severe hypertension still can have an adverse outcome even if the placenta has been functioning normally. So this is where I think we're going, this future of biomarkers for diagnosis and management decisions, a biological approach rather than a historical approach, rational and reliable prediction that's been tested with multiple studies. And this can even help us move towards newer treatments for preeclampsia, so maybe a cure other than just delivering those patients. So I'm going to stop here and move on to allow our next speakers to begin. Thank you.
Yeah, very good. Thank you, Doug. In fact, that sets up Tom very nicely. Dr. McElraith is our next speaker, who will explore some novel ways of which we are now characterizing or experimentally characterizing different forms of preeclampsia. So, Tom? You're on mute.
You'd think after this many years we'd be able to get the mute straight. So thank you very much. And this is a lot of fun because I think the viewers will see how all of our talks are really starting to interdigitate and really sort of refer to each other, as Dr. Bernstein mentioned. So I'm speaking to you today from Brigham and Women's Hospital, and to get back to the point that Dr. Graves made earlier, this hospital before 1980 was known as the Boston Lying-In Hospital. So it was exactly that type of portion of the evolution of the condition. So what I'm going to be talking to you about is a test that Mirvi has developed called Encompass, and it is a screening test, and I'll come back to that in just a minute. But let me concentrate on this slide for just a moment here. I'm not going to go over each one of these points because some of the prior speakers have actually addressed these, but one of the important points that I don't think we've brought out yet is that the rate of preeclampsia is increasing. It is increasing in almost a linear, if not actually accelerating fashion in our country. And what's interesting, the portion of the disease that is driving that increase is the early, before 35 week, the more severe form of preeclampsia. So what we're hoping to do with the test that we're developing here is actually address that before the patient becomes symptomatic. And one of the key points to try to remember is we have prophylactic therapeutics. Aspirin is a prophylactic therapeutic. The problem is only about 10% of patients who have risk factors for whom aspirin has been recommended actually end up taking aspirin. So it's a little bit like having high cholesterol but not taking your anti-cholesterol medicines. It's out there. We think if we characterize patients' risks more appropriately, they'll be able to really be more motivated and be more in sync with both the prophylaxis and then also with other aspects of preventative care. So let me, let's having trouble with my computer. Okay. All right.
What did my door say?
There we go. So just to get back to the point that Eleni mentioned earlier, what we're talking about is a screening test, pre-symptomatic, trying to decide who among patients is at risk, and then equally importantly, who among patients is not at risk. Dr. Walkers spoke about the SLIT and PLGF ratios, which are on the market right now. Those are for patients who are symptomatic to help aid in diagnosis and prognosis and management. So we're actually in two separate paradigms or two separate areas of care delivery with this. This is our test. It's actually available. It was available as of 2 weeks ago. It is for a specific group, singleton pregnancies, age 35 years or older. Blood is drawn between 18 and 22 weeks. And it's important that none of the severe risk factors for preeclampsia be present, including diabetes, prior pregnancy with preeclampsia, chronic hypertension, or other major risk factors. And I'll come back to that in just a moment. But this is the test and what it appears, how it appears in its packaging. So what does the test do? What does Encompass do? Encompass actually looks at RNA biomarkers. So what is RNA? RNA is a step between what genes are expressing and what proteins are being formed. So what it really tells us is what genes are active in a specific situation. And what we're doing is we're collecting RNA from the maternal blood and analyzing it for patterns that are specific to the developing risk of preeclampsia. And I'm going to return to that in just a moment. This slide is really the core of what we're getting at. So if you take 100 women who are pregnant, singleton pregnancies, 15% will be high risk, meaning they will have had prior preeclampsia hypertension, kidney disease, other conditions that are high risk. This is not what our test is designed to do. We will work on that in the future, but for this first version of the test, what this test is looking at is this middle category here. What's important to realize is 85% of all pregnancies are in this middle category. They have at least one risk factor, moderate risk factor for preeclampsia. And this may be race. It may be that the patient had IVF, that the patient is 35 years old. There's a whole host of moderate risk factors. But that's 85 plus the 15%. That's a large percentage of pregnancies who actually have a risk factor for preeclampsia. So if 85% of your pregnancies are at risk of a moderate risk factor for preeclampsia, it's almost like saying nobody's at risk. It's just really not a useful metric at that point. And so what the Encompass test does is it breaks that down. Among patients who are tested, remember it's between 18 and 22 weeks gestation, 1 in 4 will go on to become high risk. But 2 in 4 will actually be low risk. So among the 1 in 4 who are high risk, these are patients, remember, they did not have high risk characteristics prior to this, but they are now in the same category as a patient who has had preeclampsia in a prior pregnancy. So their risk ratio goes up dramatically by over a 200% increase in the risk of preeclampsia in that category. Now, the low risk category is also important because their risk category actually goes below the baseline risk. They are now at much lower risk of preeclampsia. And remember, these are patients who had risk factors, and that was why they were in the moderate risk category to begin with. So now they are the same as a patient who has absolutely no risk factors. So the test will actually help sort out what's in the middle and apportion patients appropriately. This is the validating study for the test. It was published just 2 months ago now. And this study is important for 2 reasons. First reason being that it does validate the test in an independent population of over 9,000 pregnancies. But equally important, and this gets back to what both of my colleagues have just mentioned, is it begins to sort out the underlying etiologies, the underlying causes of preeclampsia, and demonstrate that they're different at different stages of preeclampsia. So patients who are positive for the Encompass test are at risk of the earlier form of preeclampsia before 35 weeks. And what we've seen in looking at the types of RNA that are being expressed is that this is a disease associated with the placenta. It is a disease that seems to be centered on the placenta and is at least a placental association, if not origin. What's important to realize is the blood is being drawn between 18 and 22 weeks. So this is before the patient is even symptomatic. So that's the opportunity for prophylaxis at that point. But it also points out, as both of my 2 prior colleagues have said, that this is a disease that is of placental origin. What's interesting is the preeclampsia that occurs towards term, that occurs after 35 weeks, seems to be, with respect to the RNA, a much different disease. It's a disease that is associated with immune reactivity, immune inflammation, and it could be an entire different subtype. And I think that's important because if we begin to try to treat each disease as the same disease, our treatments are going to be effective. But here we have the opportunity to really be more specific and more centered on what version of the disease we're treating. This is still early days. We're still developing the molecular subtypes of the condition, but this is, I think, an important step forward. So the next question comes up, okay, patients at risk, what do we do? Well, we just spoke about aspirin, and we hopefully will motivate the patient to be on aspirin. We're also anticipating the patient would then be, if she was part of our program, would then be able to receive at-home messaging as well as blood pressure monitoring and symptom education and support. So to sum up, what we're proposing is a test between 18 and 22 weeks. It is presently available on the market, an action plan that has been demonstrated, and then a risk tracking and alerts and SMS communication and verification and support to the patient. And let me end right there.
Thank you, Tom. Eleni, did you want to say something?
Yeah, I was just, we have so many questions, wonderful questions coming through the Q&A, and of course we won't have time to get to all of them, but I thought let me just kick off a few that are sort of burning issues for patients. And Ira, I think maybe you might hone in on some of the questions that come out from a more clinical perspective. But one of the things that patients want to know, in addition to how do I get these tests, is if I am able to access these tests early in my pregnancy and in any way, shape, or form identify myself as being at higher risk for preeclampsia, what can I do and what should my doctor or midwife be doing? That's question one, and I don't know who would like to take that, but Dr. Kingdom and Dr. Wolkers, you both are actively using tests in your clinical care right now. How do you guide your patients who seem to have seem to have a higher risk for developing preeclampsia?
I'll give it a start. I think what we're increasingly are trying to say here in Canada is the question is, why would you not take aspirin? Invert the question, because it's actually, you can buy it yourself. It's actually pretty safe in 99% of patients and doesn't require any monitoring. So in fact, we're adopting a different strategy, which is to head towards testing a universal aspirin prophylaxis. But we can come to that perhaps if we wish. So our view here is a big push on inverting the question and asking, are you somebody who doesn't need aspirin rather than the other way around? Because research we just published this month in our own national journal shows that we're doing poorly as well. We're about 1/3 of our patients who are appropriate for getting it according to clinical guidelines. I think we do have to develop tools to help people to, for example, an ASA app. So you get pregnant and it's linked to Pregnancy Plus or other tracker programs. Do a quick check to see if you hit the buttons yes, no for aspirin based on current clinical practice guidelines. That's the first thing. I'll stop there, but I would say that a big push on clinically based aspirin prophylaxis is overdue, definitely.
I agree. That's the one thing that we can advise easily. Unfortunately, even in the best trials of aspirin where compliance is tracked and taken, its ability to prevent preeclampsia is not 100%. It's maybe 30% to 40% at best. So we still need medicines to help prevent the disease and interventions. I certainly would counsel any patient that healthy cardiovascular habits can be beneficial. So appropriate pregnancy weight gain, low salt diet, staying fit, exercising, managing any other medical comorbidities aggressively if necessary. Those can all help as well. But at the bottom of the day is, if you're identified as high risk, then there's a potential the placenta will start to experience that dysfunction that leads to preeclampsia, in which case early diagnosis becomes the next important thing. So education is critical. Having those little apps on your phone or seeing the posters that the Pre-eclampsia Foundation itself produces to warn moms about early signs and symptoms so they can seek care is important. Being able to transfer care from a low resource setting to one of higher resource could be important, especially, in Canada. I know there's large areas where patients may be in a rural setting with only midwifery care or kind of a lower level care. So we would do that. We'll transfer patients to a high risk care and increase the surveillance. But unfortunately, we just don't have a way to prevent it in those women who are identified early on as being at risk in every case.
Yeah, just one comment here. In 3 provinces in Canada, we have pilot programs providing equity for maternity care through PLGF screening at 24 weeks. So a provocative approach here would be to push universal aspirin prophylaxis and have a non-inferiority trial to stop aspirin based on a normal PLGF test when you do GDM screening. And the irony is that people get GDM screening, but in fact, placental complications produce at least 10 times the morbidity and mortality than minor diabetes. And it's high time that we did PLGF screening and not GDM screening for most patients. So I hope that we can demonstrate the massive difference in maternal fetal morbidity between those two disorders soon.
So
I do have a
Anybody else
question
thinks?
for
Yeah.
all of you all. This comes up over and over again. We have done a great job of shining the light on postpartum preeclampsia, hypertension that shows up for the first time after delivery or that continues even after the placenta has been delivered. I'm wondering if any of these tests have actually been examined in the postpartum period, and how would you even hypothesize that this is what causes postpartum preeclampsia if all the evidence suggests that we're flushing the system with the placenta and these toxins are being, delivered and so on and so forth. So anybody who has some insight about how any of this shines a light on postpartum preeclampsia, I think a lot of patients would love to hear that.
so I think we're working on it. The Encompass test is not designed for postpartum, but we have data and are looking at it. It's still a great question. What is postpartum preeclampsia? And I think part of the answer may be that while the placenta has been delivered, that doesn't mean all the trophoblasts are out of the system yet at that point, and there may be some residual trophoblastic stimulation that evolves over time. But it's not 100% clear. It may simply be term preeclampsia that came late, or there may be some residual trophoblastic influence still, even though the placenta is out, and it takes some time for it to actually completely regress.
I'm going to go ahead and just take the prerogative to comment. It's pretty clear, and there's evidence, experimental evidence, that with HELLP syndrome, you get more rapid resolution when you scrape the uterine lining following delivery at the time of C-section. So that's a study that was done at the University of Mississippi, and I think was reasonably compelling, going along with Tom's issue of whether, or raising the point of whether there's persistent trophoblast in the uterus that removing can help. I think there are potentially other explanations about postpartum eclampsia and preeclampsia that are not specific to placental or trophoblastic origin, and it relates to the overall underlying hypothesis about where this disease really comes from and whether the strength of the placental disorder is an association with disease or truly causative. And I don't think we know the answer to that yet, but I think we will know that in short order as a series of studies are now being conducted. I'd like to pose one question which relates, Eleni's, to Doug, and that's the question of HELLP syndrome in the same way of postpartum disease. What do we know about the prediction of these placental markers for HELLP syndrome as a unique element of the preeclamptic phenotype?
I can chip in there because we actually are funded by the Preeclampsia Foundation to answer that question in part. So we've had about 70 patients present with HELLP syndrome since we've had PLGF testing in the last, maybe say 5 or 6 years. And I think like 95% of them have low PLGF. And the vast majority have bilateral abnormal uterine artery Doppler on presentation as well. So, and I think that, for example, for patients who have had HELLP syndrome, they're often given a very poor future prognosis. But at 16 weeks, uterine artery Doppler and PLGF has a really high negative predictive value for not getting HELLP syndrome. I just delivered somebody yesterday who had intensive care with HELLP syndrome in their first pregnancy, and PLGF of 130 at 16 weeks and bilateral low PI uterine arteries, and she just didn't bat an eyelid the whole way. So it is possible to give patients individualized prognosis in their future for HELLP syndrome using simple tools. And the vast majority of HELLP syndrome patients, in our experience, do present with low PLGF. And the other thing, the proxy for high S-split is a urine PCR. So we don't have S-split, but we would find heavy proteinuria as a manifestation of the renal injury from high S-split.
Yeah, I always like to point out the fact that when using certain cancer drugs that target VEGF, essentially targeting placenta growth factor, men get hypertension, proteinuria, and can even have seizures. So there's such strong evidence that that syndrome we identify as preeclampsia is specifically due to this absence of the right level or the right function of that growth factor. How it presents postpartum, I can't state for sure. But we do know that patients that have lower PLGF and higher SFLT, they have longer persistence of endothelial dysfunction after delivery. So I just have to imagine that when the endothelium is truly sick, it just takes a while to come back to normal function. After all, that preeclampsia was brewing for the duration of that pregnancy, 32 to 40 weeks. So within 3 or 4 days, maybe not everybody's vascular system is back to baseline.
I agree with
I think
Doug.
it's true. Sorry,
I,
go ahead,
I,
Cornelia.
yeah, I said I agree with Doug. I think there's also data that shows that persistent circulation of S-split may be associated with cardiac dysfunction as well. And we know that preeclampsia is a cardiovascular disease. So how women can clear their S-split or how long it takes may have some prediction in postpartum preeclampsia. And hopefully, as we learn more about these biomarkers, we'll be able to predict those women who may be more likely to have postpartum preeclampsia.
I had another
Eleni, we
comment to ask
are over
people.
time. I'm sorry, John, but
I know we are out of time, and I was going to ask Dr. Graves one last question, or really any of you all. We're at a very critical juncture for these tests being introduced. Some of them are being processed through FDA clearance. Some are being developed as laboratory developed tests. How can patients access these if their doctor is not already using them?
So for our test, encompass.com, it's on our website, or it is the website and can be accessed through the website.
The tests are available through national laboratories as well. So the site does not have to have a device in their hospital or in their clinic. So through LabCorp or through Arup Labs, again, the physician will have to send this. I don't foresee a state where patients will be able to self-send samples off for analysis. That's not currently permitted.
And I was going to say, due to national labs at first, especially for the first trimester test, which is an outpatient test, you can, I do this all the time. I see patients who don't live in Tennessee, but I can order it through the national lab and they can get that test performed.
Wonderful. Thank you. Dr. Bernstein, any final comments? We are going to sign off, trying to keep it as close as possible to the hour that we promised.
I just want to thank our experts. I mean, they're all bringing some unique backgrounds and both clinical and scientific skill sets to the table as we try to better understand what's really going on with this disease more broadly. So thank you for all for participating and for your work.
Very good. And the last thing, we are going to pop up a slide that offers a quick poll for patients who are listening to this. If you'd like to be part of a first look at a video that we're producing that will try to summarize some of the information we've presented today, we are going to be adding it to our family of educational explainer videos. Take a look at this and let us know if you would like to be part of a kind of a beta group to review this video before it goes live to the public. And we will be presenting this shortly. So take a look. You should have a poll that just popped up on your screen. Answer that, and we will be in touch if you are interested in helping us with this.
I am.
Hosts and panelists are not eligible to
Oh,
participate.
darn. Okay.
For everyone else, take a moment to answer that. And thank you. And again, as Dr. Bernstein said, thank you to honor all of our panelists for not only presenting today, but for doing the work, really going above and beyond to care for preeclampsia patients. We are extremely appreciative, and you make our job at the Preeclampsia Foundation. We're inspired and motivated by you, and we are inspired and motivated by the thousands of stories that we are presented with every day. We will continue to work. Thank you, everyone, for joining with us today. Have a wonderful afternoon or evening or morning, wherever you hail from.